I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist at McMaster University in Canada, and I'm delighted to have with me Professor Milton Packer, Principal Investigator of the Emperor-Reduced trial that was just released at the ESC. Professor Packer, welcome.
Thank you so much.
Your trial tested the efficacy of empagliflozin relative to placebo in patients with heart failure and reduced ejection fraction, and you included patients regardless of diabetes status. Tell us about the methodology and results.
Well, we were very interested in SGLT2 inhibitors for the treatment of heart failure with reduced ejection fraction because in the large-scale cardiovascular outcome trials in type 2 diabetes, we saw this very consistent signal of benefit on reducing heart failure hospitalizations across 4 different trials, all with SGLT2 inhibitors, all with different members of the same class, all with about a 30% reduction in the risk of hospitalizations for heart failure. And it didn't appear to have any relationship at all with their ability to lower blood glucose. So we and others thought, well, if this drug prevents heart failure events and it doesn't have anything to do with blood glucose, then maybe it will prevent heart failure events in patients with established heart failure, whether or not they have diabetes. And so the 2 trials were launched about the same time. About a year ago, there was a trial with dapagliflozin in heart failure with a reduced ejection fraction, with or without diabetes. That was a trial called DAPA-HF. It was presented a year ago at the European Society of Cardiology meetings. And that trial met its primary endpoint, and it had very exciting results. We studied in Emperor-Reduced also patients with heart failure and a reduced ejection fraction with and without diabetes, but we studied by intent a sicker patient population. And we designed the trial to focus on patients with an ejection fraction of 30% or less. We specifically developed inclusion criteria to focus on these individuals. Our average ejection fraction was 27%. 75% of our patients had an ejection fraction of 30% or less. So it's a different population than studied in DAPA-HF, but very complementary. DAPA-HF a little bit towards the milder end of the disease spectrum, and we studied patients on the more severe end of the disease spectrum. And the result was, as a result, we had lower ejection fractions. We had higher levels of baseline natriuretic peptides, 40% higher than in DAPA-HF, worse renal function, and a greater use of sacubitril/valsartan. 20% of our patients were taking background therapy with a neprilysin inhibitor.
Right, and there was also a higher use of ICD-CRT therapy in the EMPA-reduced trial relative to DAPA-HF.
So in many ways, all appropriate background treatments for heart failure were used more frequently in Emperor-Reduced, and maybe that was related to the fact that we enriched the patients for those with really poor systolic function.
Right, and risk is a mixed bag, isn't it, in trial design? On the one hand, a higher risk population may be more sensitive to the treatment. On another hand, there might be more progression along the disease state, and they might be actually less sensitive to the intervention, and there's really no way of knowing without testing it in an RCT.
Well, that's exactly right, and that's such an important point, because we don't know in advance whether an enrichment strategy is something that will yield a greater treatment effect or a more compelling result. Typically, every trial uses some enrichment strategy. Sometimes it's a gentle enrichment strategy, and sometimes it's more vigorous enrichment strategy. And the major reason we do that is that for the trial to be feasible within the timelines that are relevant and within the budgetary restraints, we really need to have patients who have events. And if patients don't have events, then we have no statistical power to test a hypothesis.
Right. And so patients had a slightly lower EF, a slightly higher N-terminal proBNP, a lower proportion had a past history of hospitalization in the preceding 12 months. Tell us about who was excluded from the trial.
Well, we tried very hard not to exclude too many people. In fact, something that we did that DAPHF did not do was we enrolled patients with an estimated glomerular filtration rate of 20 to 30, which is the lowest of any trial that I can think of in the area of heart failure with a reduced ejection fraction. Typically, when we do these trials, we say, okay, if it's less than 30, then their outcomes are driven maybe by elements not related to heart failure. So maybe we shouldn't include them. But in the case of Emperor Reduced, we included people down to an eGFR of 20. And we had about 300, more than 300 patients with an eGFR between 20 and 30. So not a small patient population, and a unique population, given the fact that this group of patients hasn't been recruited in earlier trials.
Right. And importantly, you excluded those with recent ACS, those with chemo-induced cardiomyopathy and peripartum cardiomyopathy, those with valvular disease, I believe, and those with acute decompensated heart failure. And I mention this only for our clinicians who will seek to implement study results within their patient population.
So I just want to make sure we included people with a prior myocardial infarction, but not if it was recent. Not if it was recent. We included people who had coronary disease, stroke, atherosclerosis, peripheral arterial disease, but not if they had a recent ischemic event.
Right.
That's pretty typical of these trials.
Absolutely. And I think you used 90 days as a cutoff.
I think we did. That's also a typical cutoff. Different trials do different things. It is very important to emphasize one thing that you already emphasized, which is we didn't study people with decompensated heart failure. And some heart failure trials focus on those individuals, but most large-scale outcome trials study people who are not acutely hospitalized, who have been discharged and are relatively stable. So our patients were sicker, but they were stably so. Right.
So I think the majority of your patients had NYHA class 2 symptoms. They were recruited from across the world, and they were on good background medical therapy, as you mentioned. What were the principal findings of your trial?
Well, I think we specified in advance, we had a very interesting selection of endpoints, because unlike a lot of trials, and as you know, these outcome trials tend to have numerous endpoints, and sometimes they're 10, 15, 20 endpoints. And there's always an issue when you have that many endpoints of false positive rates due to multiple testing procedures. And we wanted to make sure that we avoided that problem. So what we did something really different. We specified only 3 endpoints as part of our hierarchical testing procedure. So we had a hierarchy of testing where a the test was done on the first endpoint first, and if that was achieved, then the second endpoint, and then the third, and we only had 3. And we chose these endpoints very carefully because we said, these are the endpoints that really matter to us in determining whether the drug actually was effective or not effective. And so at the very beginning of the trial, years ago when we first designed it, our 3 endpoints were, primary endpoint was cardiovascular death and hospitalization for heart failure as a composite. Second endpoint was total hospitalizations for heart failure, first and recurrent events. And the third, which was really unusual for a heart failure trial, was a renal endpoint, which was the slope of decline in estimated glomerular filtration rate during double-blind therapy, coupled with a composite of end-stage renal events. So we had pre-specified a combination of dialysis, renal transplant, and a profound sustained decrease in EGFR as a pre-specified, as our major renal endpoint, our major renal outcome measure.
Right. And so after about 16 months, which I believe was the median duration of follow-up.
Exactly.
You found that, I don't want to steal your thunder.
We just in order of the hierarchy, we achieved our first endpoint in the hierarchy. Empagliflozin reduced the risk, the combined risk of cardiovascular death and heart failure hospitalization by 25%. Or our second endpoint in the hierarchy, which was our first secondary endpoint, empagliflozin reduced the total hospitalizations, first and recurrent events, by 30%. And for the third in our hierarchy, the slope and decline in EGFR, empagliflozin significantly and meaningfully reduced the rate of decline in renal function. And on the renal composite of serious renal events, reduced that risk by 50%. We had never seen that kind of renal benefit in a heart failure trial. And so for each of our 3 endpoints, and again, these were the 3 major endpoints we specified in advance, the effects were not only clinically large, but they were all highly statistically significant, p less than 0.0001. So we were very, very happy with the results. It's very uncommon when years ago you say, look, there are 3 endpoints that matter, and then years later you get the results, and those are the 3 endpoints that you achieve.
Right. Remarkable. We would love to have your insight into the implications of this work, how they fit with the DAPA-HF findings, and how they might deviate a bit from the DAPA-HF findings. So
first, it's very important to look at DAPA-HF and EMPEROR-reduced together. And to do that, you sort of have to line them up, and you have to look at where they reinforce each other and where they might be a little bit different. Because they did study similar patients, but complementary patients. They weren't exactly the same. And so if you line up the 2 trials, there's this striking concordance with respect to hospitalizations for heart failure. So if you look at cardiovascular death and hospitalizations for heart failure, which was our primary endpoint and very similar to the primary endpoint in DAPA-HF, there was a 25% reduction in the risk of cardiovascular death and hospitalization for heart failure, and it was 25% in each of the 2 trials. with confidence intervals that were almost exactly identical, striking replication. Total hospitalizations for heart failure across the two trials, 30% reduction in risk, striking replication, exactly the same confidence intervals, exactly the same level of statistical significance. We achieved an effect on our renal composite that was larger than that seen in DAPA-HF. We had a 50% reduction. They had about a 29% reduction in risk. We had statistical significance in our trial. They didn't in DAPA-HF, but it's very hard to do these cross-trial comparisons, especially when the number of events is relatively small. Conversely, we found an 8% reduction in cardiovascular death, and DAPA-HF found an 18% reduction in cardiovascular death. Cardiovascular death wasn't part of their hierarchical testing procedure, but they did achieve nominal levels of significance, and we did not. And we wondered about whether, why was there an 18% risk reduction in DAPA-HF and 8% in EMPEROR-reduced? Is there some difference here that is meaningful? So what we did was we looked at the totality of available data, because that's what you need to do. Not each of these trials has confidence intervals around their estates. And we knew that the confidence intervals on cardiovascular death overlapped between the two trials substantially. But the question is there really a systematic, a predictable, a reliable, a replicable difference in the findings? So we went back to the type 2 diabetes trials. And there were two large-scale trials in type 2 diabetes, a trial called DECLARE TIMI 58 with dapagliflozin, a trial called EMPEREG Outcome with empagliflozin. And in those trials, when you studied and compared exactly the same subset of patients in the two trials, there was a 41% reduction in cardiovascular death with empagliflozin, an 8% reduction in cardiovascular death with dapagliflozin. Well, the 41% reduction in cardiovascular death in empagliflozin was statistically significant. The one with dapagliflozin wasn't. So we had a pattern in diabetes that was exactly opposite to the pattern seen in heart failure with reduced ejection fraction. When you see that, what it tells you is that the effects of cardiovascular death with these drugs are heterogeneous. And the effect size is probably pretty modest. It's about a 15% reduction in the risk. And we found that when we did a meta-analysis of the two trials, which we published in Lancet just a couple of days ago. We found a 14% reduction in cardiovascular death overall with no heterogeneity between the two trials. And interestingly, when the DECLARE investigators did a meta-analysis of cardiovascular death in the type 2 diabetes trials, they found a 15% reduction in the risk of cardiovascular death in the type 2 diabetes trials. So I am getting the impression that these drugs have an effect on cardiovascular death, but it's in the realm of about 14 to 15%. And depending on the trial, depending on the population, depending on the disease state, some trials hit a little bit on the high side, some a little bit on the low side, but no systematic difference between the drugs favoring one drug or another. And in fact, the concordance of the findings with dapagliflozin and empagliflozin across the two trials are really amazingly striking. And they're also concordant with the effects of other SGLT2 inhibitors, in type 2 diabetes. So we are so fortunate to have 6, 7 large-scale outcome trials with SGLT2 inhibitors, not just in diabetes, not just in chronic heart failure with a reduced ejection fraction, but also in chronic kidney disease. One of the very important trials presented at the ESC was DAPA-CKD.
Right, I just interviewed the investigator for that trial as well, so we have a segment on that. I agree, great evidence for a class effect and a terrific few years for the SGLT2 inhibitors. I wonder if you could briefly touch upon the adverse effects seen with empagliflozin.
So in our trial, drug was exceptionally well tolerated. Serious adverse events were actually less common in the empagliflozin group than in the placebo group, especially when it related to serious adverse effects related to the heart and the kidneys. Mm-hmm. Now, with respect to non-serious adverse events, there was no excess in volume depletion, hypotension, hypoglycemia, no ketoacidosis, no imbalance in urinary tract infections, no imbalance in bone fractures, limb amputations. There was an imbalance in uncomplicated genital tract infections, which was seen in the trials with type 2 diabetes. Mm-hmm. But that was only seen in 1% of patients. Mm-hmm. So what's really interesting about this class of drugs is that they don't have some of the classic side effects of heart failure therapy for reduced ejection fraction that we've seen in other trials. When we use angiotensin receptor neprilysin inhibitors, beta blockers, spironolactone, we see hypotension, we see bradycardia, we see hyperkalemia, we see renal insufficiency. And we don't see any of those with SGLT2 inhibitors.
Exactly. So reassuring findings from a safety endpoint. So in summary, in this trial that you led, empagliflozin was superior to placebo in improving outcomes among patients with HFrEF who were on excellent baseline guideline-directed medical therapy, on optimal ICD-CRT therapy, who had poorer renal function than DAPA-HF, regardless of diabetes status. Important findings that provide great hope to our patients with HFrEF. Thank you so very much for your time today. I was so delighted to meet you and talk to you, and I hope our paths cross at another meeting that's face-to-face potentially. It's been an interesting virtual meeting. It was very successful, very well attended. I know that your results broke out a little bit sooner than you had wanted, but great reasons to celebrate. Thank you so much, Professor Packer.
Thank you so much. This has really been a delight. Thank you.